Tonight is the first of several of the next several weeks as part of the Smilow Shares program, where we'll be talking about cancer genetics and hereditary cancer syndromes and how to best take care of yourself if you or a loved one or friend has one of these syndromes. So tonight, welcome. I'm so happy that you could join us. And tonight is going to be a night discussing cancer genetics, really to provide an overview. So I'll start off with just a brief introduction, sort of overview of the program, and then I'm joined tonight by some fabulous members of our team. You'll hear from Amanda Ganzak, one of our lead genetic counselors. You'll hear from three of our fabulous genetic counselors, Camille, Varin-Tremblay, Elizabeth Del Buono, and Alexandra McClellan. So we'll cover an overview of topics, and then there'll be opportunity to ask questions at the end. So with that, I will go ahead and get started by just providing you an overview of our Smilow Cancer Genetics and Prevention Program. So hopefully my computer is working. Come on, slides. I promise you this is working. There we go. Are you controlling, Alex? Do you want to go ahead and control? That's fine by me. Okay. Alex, you go ahead. So our Smilow Cancer Genetics and Prevention Program was actually started in July 2014 as an organization. The Cancer Genetics Program at Smilow had existed for several years prior to that, but meanwhile there had been a lot of high risk and prevention efforts that had kind of siloed themselves within the hospital. And so in July of 14 we decided to join together, and we formally launched in the summer of 2015. So we've been around for about 5 years. Our goal was really to come together with genetic counseling, with oncology, with high risk and prevention programs, and really build almost a one-stop shop, if you will, for patients with hereditary cancer syndromes or who might have a strong family history. Our home base is shown here. We reside, if you will, on the St. Raphael's campus in the Orchard Medical Center. Our windows are just to the left of that picture. But we're not only present in New Haven, but we have locations at St. Francis, at Bridgeport Hospital, Trumbull, Lawrence Memorial, Greenwich Hospital, and Torrington. We are doing visits on site. We have opened up post-COVID or during COVID, and we do have telemedicine services available as well. Alex, could you go to the next slide? Thank you. I'm technologically challenged these days.
It appears I am as well. Hold on. There we go.
There we go. So the program that we really endeavor to build is not just about providing clinical care, though that obviously is the foundation of what we're trying to do, is to take good care of patients. But we have an interest in research, we have an interest in education, and we have an interest in community outreach and doing programs like this so that people can learn more about these programs and these issues. The next slide. Thank you. And look at our fabulous team. So the medical director of the Cancer Genetics and Prevention Program is the esteemed Dr. Xavier Yor, who is a gastroenterologist. And the program is also led by our scientific director, Dr. Alan Bale, who is a geneticist. Our lead genetic counselors are Claire Healy and Amanda Ganzak, both of whom are here tonight on the call. And we have several programs, including myself. I help to lead the breast program. Xavier leads the gastroenterology program. Gynecology, I know many of you know Dr. Elena Ratner, Dr. Masuda Zodi. Our pancreatic program is led by James Farrell. And for those with more rare or specific genetic syndromes, they're seen by Alan Bale. The next slide. Thank you. And here's our team. Our team continues to grow. So you have here a list of, gosh, I think we're up to 9 other genetic counselors listed here. We have assistance by Susan Schmiel, our APRN, and we've got a fabulous staff. And special thanks to Aparna for help setting this night up. The next slide. So in the next few minutes, I'll go through just the highlights of each of our specific programs. So the program that I've helped to build is the Breast Cancer Genetics and Prevention Program, where we're really trying to take comprehensive care of our patients, both in providing risk assessment, education, screening, and really multidisciplinary care for women who might be at increased risk of breast cancer. So again, I've mentioned myself and Sue Camille, but we have Dr. Karishma Mehra, Dr. Anka Bulgaru, and Jenna Addison at different locations throughout the state. And we seek to help those women with a strong family history, a genetic predisposition, or women who might be at risk for other reasons, such as breast atypia. Next slide. Then, of course, there's the colon cancer genetics and prevention program, again, trying to provide the same type of care for people who might be at increased risk of colon or other gastrointestinal cancers. So Sue is the glue that holds us all together. So Xavier works with Sue in his program, primarily based in New Haven, and again, looking for folks with a strong family history of colon cancer, a genetic predisposition, or a significant history of colon polyps. And then lastly, and on my last slide, is the Pancreatic Cancer Early Detection Clinic. So this is, again, run by Dr. James Farrell. He is joined by a fabulous nurse, Scott Miranda, and Sue. And their clinic runs out of New Haven. And again, looking at patients, really trying to take good care of patients who might be at increased risk of pancreatic cancer. So that may be due to a strong family history, again, a genetic predisposition, or those folks who have hereditary pancreatitis. One unique feature about Dr. Farrell's clinic is that he helps to run the CAPS-5 study. We are one of several national sites who is currently doing an active screening study to try and find out whether aggressive surveillance may help with early detection and potentially treatment for those at risk for pancreatic cancer. So those are the highlights. More to come. And oh my goodness, how could I almost forget the Gynecologic Cancer Genetics and Prevention Program? Oh, perhaps the most important of all of these. Really what this is we have partnered with a Discovery to Cure program, which really represents the clinical arm. So I know this program is near and dear to many of those folks in the audience. This program is led in many ways, was established by Dr. Ratner, and she is joined by Joanna Daddario, who is fabulous. They are stationed in New Haven, and Dr. Masuda Zodi provides care at Bridgeport Hospital as well. So folks with a strong family history, genetic predisposition to GYN cancers. So forgive me, I almost omitted that. And genetic counseling, of course, is where it all begins. So truly, to really understand your risk, really, especially if you've got a strong family history or otherwise, a meeting with a genetic counselor, understanding your risk, learning if you have hereditary syndrome is really the best place to start. And so with that, I will hand it off to Amanda Ganzak, and she can take it from here. Thank you.
All right. Well, thank you everyone for coming and joining us tonight. I hope we can piece out a couple new information that you might not be aware of, and I'm excited to kind of give us a little bit of background, the ABCs of HBOC. So I'm going to talk a little bit about an overview of hereditary breast and ovarian cancer, as well as kind of take us through a timeline, really where did we start and where are we at this point in time. So all right, so I'm going to start by going over a little bit of the background. I'm not going to spend a whole lot of time on this, but when we look at what are the different causes for cancer, many people, when they come to see a genetic counselor like myself, are very surprised to learn that the majority of cancer, 70–75% of cancer, is sporadic. It's just random. A lot of the factors that can contribute to a sporadic onset cancer can be numerous. It can include just the normal aging process, lifestyle factors like smoking history, alcohol, diet can influence our risk. We can see environmental and occupational exposures can put us at risk for particular types of cancers, viruses, factors we don't even know about. And so for most people, it's really a combination of all these different factors that can contribute to someone being diagnosed with cancer over the course of their lifetime. But what you don't see in that list are genetics, our family history. So for most people, they really don't need to see someone like myself to do genetic testing, since most cancers is not falling into a hereditary category. There is about 5–10% of cancers that are hereditary. And this is really where we want to focus today on our conversation. And when we see cancers that are hereditary and fall in this genetic category, we will see that individuals have a much greater risk to develop cancer. They are more likely to be diagnosed at younger ages. They can even develop more than one cancer through their lifetime. They might even develop rare cancers, and their family members will have an increased risk for cancer. And so it's really important that we can identify those cancers and those individuals who fall in this hereditary category so that we can address each of these factors for them and their family members. So what do we look for when we're assessing someone's personal and family history? So we ask a lot of questions, and I'm sure many of you, if you've met with a genetic counselor, have answered a lot of these questions about your family history. But some of the patterns or red flags that we're looking for when we ask all these questions is looking at, oop, I don't know what just happened, sorry. Hold on. Let's see, does that work? All right, thank you. All right, so I'm looking to determine if the cancers are diagnosed at early ages, such as breast cancers diagnosed prior to the age of 50. Seeing if there's multiple relatives on the same side of the family with breast, ovarian, prostate, and pancreatic cancer. We can see rare cancers like triple negative breast cancers in these families, ovarian cancer, men with breast cancer. Some of these cancers can even be rather aggressive. When we start to see prostate cancers that have spread to other parts of the body, that can increase the likelihood or suspicion for an inherited risk for cancer. And if we see that there are individuals in a family that have developed more than one cancer, someone with bilateral breast cancer or breast and ovarian cancer is another red flag. And the last question that we will ask individuals is if they have an Ashkenazi Jewish or Eastern European background, as that also could increase our suspicion for hereditary breast and ovarian cancer. Now, if we look in just 2020 and say, you know, how much of cancer is diagnosed just in this year alone, we will see that approximately 191,000 men will be diagnosed with prostate cancer, and the #1 cancer for women is breast cancer with 267,000 people. So if we estimate that about 10% of each of those categories will be hereditary, we will see that about 19,000 of those prostate cancers and about 27,000 of those breast cancer cases are due to an inherited risk factor. Now imagine that times all the relatives that also would be at increased risk. So this has real, widespread impact, not just for those patients who are newly diagnosed, but also for their relatives and their family. And so what really causes hereditary cancer? Well, it really just boils down to our genes. And genes are in every cell of our body. They are our instruction manuals. They really help tell our body how to work, how to function. They help us, tell us what color eyes we're gonna have and all of that. So they all have different roles and are very important for us to be able to have genes that are functioning properly. And where do they come from? They come from our parents. We inherit one copy of our gene from our mom and one copy of our genes from our dad. And so while some of our genes are responsible for things like our eye color or controlling our heartbeat, there are other genes that are responsible for regulating or preventing cancer growth and development in our bodies. These genes are really important for us. And if one of these cancer prevention genes has a defect in it, it can cause an increased risk to develop particular or specific types of cancer. And so what are genes and mutations and DNA? This is a lot of new language and words for a lot of people when they come to meet with a genetic counselor. So all of our genes are made up of DNA, and it really is just the DNA is the spelling of our genes made up of particular letters that come in a very particular order or sequence that you can see here represented by the T's, the G's, the C's, and the A's. And they're all strung together to spell out that gene to make sure that it's working properly. But what happens when there is a change in that genetic spelling or sequence of the gene? Here I'm going to use the example where this letters went from G, T, A, highlighted in red here, and a mutation has taken place such that the letters have been changed to T, A, and G. Now, this is not what the genetic spelling was supposed to be for this gene. And by changing this, by changing that spelling, this mutation now stops the gene from working. And when we see these in these cancer prevention genes, these mutations lead to increased risk for particular types of cancers. Now, when we specifically talk about hereditary breast and ovarian cancer, BRCA1 and BRCA2 are the genes that are most commonly associated with hereditary breast and ovarian cancer families when someone has a mutation within one of these two genes. However, they're not the only ones. So stay tuned. Camille's going to touch on that right after I'm done here. But when we look through time, BRCA1 and 2 are still the highest contributing hereditary factors for breast and ovarian cancer. When we look among the general population, we have seen about 1 in 400 individuals will test positive for a mutation in BRCA1 or BRCA2. However, when we look in the Ashkenazi Jewish population, that number goes down to 140. So it's a much higher chance that we will find a BRCA mutation in someone who is Ashkenazi Jewish, especially if they have a personal and/or family history of BRCA-associated cancers. So it's why we ask the question when we are meeting with patients to see if that is an added factor that we should be considering in our risk assessment. So when we look closely at BRCA1 and we talk about the risk for cancer, I want to be able to compare that with what we see in the general population. So the general population risk here in this figure is represented by the color blue, and the top bar in green is the risk associated with someone who has a BRCA1 mutation. So women who have a BRCA1 mutation have as much as an 80% risk, but can range somewhere in the 60 to 80% risk over their lifetime to be diagnosed with breast cancer, compared to about the 12% risk we see in the general population. But in women with BRCA1 mutations who have already had a breast cancer diagnosis, we also see that they have a higher chance to develop a second newly, totally unrelated breast cancer. And that can happen either in the same or the opposite breast, wherever they might have remaining healthy breast tissue. That risk, what we have learned more recently as we continue to study these families and do genetic testing, that the risk to develop a second breast cancer is somewhere between the range of 20 to 40% risk. That risk can be very dependent on a woman's age in which she was diagnosed with her first breast cancer. So if she was very young when she was diagnosed with her first breast cancer, she would have the higher end of that range, closer to 40%, to be diagnosed with a second breast cancer, versus someone who might have been in her 50s with her first breast cancer. So there can be an influence of the age of onset of the first breast cancer in predicting the likelihood of a second breast cancer. Women with BRCA1 mutations also have a significantly elevated risk for ovarian cancer, as much as a 50% lifetime risk, compared to the 1 to 2% risk in the general population. Now, some of the other cancers we see in these families and with BRCA1 mutations is a slightly elevated risk of male breast cancer. For men, they also have a slightly increased risk of prostate cancer, particularly prostate cancers that can be more aggressive or be more likely to spread, and a possibly elevated risk of pancreatic cancer. Now, when we go and look at the risk for BRCA2, you will see some slight differences between these risks based on these genes. So in BRCA2 women, they will have as much as 50 to 70, 75% risk of being diagnosed with breast cancer, and similarly an increased risk to be diagnosed with a second breast cancer. Here with the ovarian cancer risk is where there's a little bit of difference between BRCA1 and BRCA2. So women with the BRCA2 mutation would have as much as a 30% risk of ovarian cancer, which is still significantly above the average risk. Men, however, have more risk if they have a BRCA2 mutation, with as much as a 5 to 8 or 10% likelihood of having male breast cancer, as much as a 20% risk of prostate cancer, once again more aggressive in nature, and as much as an 8% risk of pancreatic cancer, especially for those who have a family history of pancreatic cancer, compared to about the 1% risk we see in the general population. For both men and women, we can also see a slightly increased risk of melanoma, both of the skin as well as of the eye, called a uveal melanoma, which is very rare in the population. So why is this information so powerful? Why is it important to understand whether someone has a BRCA1 or BRCA2 mutation? Well, for one, it can help us define a more accurate and personalized risk for an individual to develop cancer. It can give us the ability to increase our screening for these particular cancers with the goal to be able to identify cancer at an earlier, more treatable stage. There are some medications, or what we call chemoprevention options, that can help us reduce risk for cancer. Examples would be tamoxifen to reduce breast cancer risk, and oral birth control pills to help reduce the risk of ovarian cancer. But we also have other risk-reducing strategies like surgery to help prevent or significantly reduce the risk in our high-risk individuals. And those types of examples would include removing the fallopian tubes in the ovaries to help reduce risk of ovarian cancer. So stay tuned to next week, because this is definitely going to get covered in a lot more detail. And this is just sort of the highlights here. In the last several years, though, there have also been targeted treatments designed specifically for those who've been diagnosed with a BRCA cancer, like breast, ovarian, or pancreatic cancer. So it's even opening options for the medical oncologist in terms of how to treat these cancers differently than they might an ovarian or pancreatic cancer in someone who has a sporadic onset. But it also allows us to more precisely identify who is at risk in the family. Individuals who have BRCA mutations have a 50% chance to pass that mutation on. And so it's important that both the men and the women in the family are aware of the familial mutation so that they can go forward with genetic testing. And just a common question that we always get is that, can men inherit these mutations? And the answer is yes. Both men and women have an equal chance, that 50% risk, to inherit the mutation that's in the family. So let's talk a little bit about the history and timeline of BRCA1 and 2 and what has changed through the years. So in 1994 was when the BRCA1 gene was first discovered, and BRCA2 was quickly thereafter in 1995. And they discovered these genes by really recruiting and studying families that had very significant family histories of breast, ovarian, and other cancers, young onset, those families that were really sticking out to them as something has got to be going on here. And that's really what has led to so much work to be able to discover these genes. And we thank so many of the patients that have come before, the patients that we see now, to be able to have gathered all this information. And in 1996, Myriad Genetics, which some of you on the call here today might have been tested through this laboratory, they had applied and started offering BRCA1 and BRCA2 genetic testing commercially. And shortly thereafter, they applied and were granted patents that were specific to localizing these genes, those letters and sequences that we talked about earlier. They patented all of that information. And so they were the only laboratory that really were allowed to do BRCA1 and BRCA2 testing after that point in time. So they really monopolized the market and really were the only option for us to be able to coordinate genetic testing for patients for BRCA1 and BRCA2. And it led to a very hefty price tag of over $4,000 to do the test. So that changed on June 13th, 2013. The Supreme Court made a unanimous decision that genomic sequences, or genes, cannot be patented. They're biology, they're there. We didn't do anything to create them, they already existed. And so no longer can we patent these genes or sequences. And back on that day when this all news came out, I took a screenshot of one of the laboratories that publicized this "your genes have been freed" message. And And it's an important one, I think, in the history of BRCA1 and 2, because it then allowed other laboratories to start offering BRCA1 and BRCA2 testing. It also allowed them to start to bundle additional breast and ovarian cancer genes along with BRCA1 and 2 when we do genetic testing, which now, as we talk about, is what we would reference panel genetic testing, and is a test we more frequently offer to patients coming through our program. But there are many more labs that now are available for us to be able to utilize, and it really changed the landscape of genetic testing. And so when I look over the past 20 years of genetic testing for BRCA1 and BRCA2, there was a lot of debate in the very beginning about who should we test for BRCA1 and BRCA2. And the reason we debated this was because it was expensive to do the test. And we also know that most people with breast, ovarian, other cancers do not have a BRCA mutation. So historically, we really focused on who was most at risk to have a mutation instead of just testing everybody. And so really the decision as to who to test was driven by the cost and not so much the benefit. And so I want to take us through a little bit of how that impact has changed our current practice. So since the Supreme Court decision in 2013, and because there are more laboratories who are offering BRCA1 and 2 testing, it really has shaken up the market and allowed more competitive pricing for genetic testing, and that cost has really come down for a number of reasons. One of the reasons being that the technology to test these genes has gotten better, faster, cheaper, and so that cost has really gone down, and many more patients can afford the cost of genetic testing if they have a potential out-of-pocket through their insurance. But patients also have the option to pay for testing out of pocket for as little as $250 compared to that over $4,000 price tag. So I think now when you look at how these things balance against each other, you can see that we probably have more benefit to do testing since the cost has gotten so much cheaper. And it really, I think, allows more people to do genetic testing than ever before. And so I want to, thank you for sticking through all of this so far, but sort of some of the takeaways of my talk here is that only about 5 to 10% of cancers fall into a hereditary susceptibility category due to inherited mutations. BRCA1 and 2 remain the most common hereditary cause of breast, ovarian, prostate, and pancreatic cancer. Genetic testing is available. It's most often covered by insurance, especially in those who have a very strong personal and family history, but costs are much more affordable in years past. So even have the option to pay out of pocket for those who are still interested in pursuing genetic testing. And if you or someone you know would benefit from our services, I'm including our phone number here, so please give us a call and do not hesitate to get this information out to anybody that you might know who would benefit from it. Thank you. I'm going to transition now to Camille. She's one of our genetic counselors, and she's going to segue us over to these additional genes that we see associated with hereditary breast and ovarian cancer.
Okay, hi. So my name is Camille, and thank you for being here tonight. The name of my talk today, I just need to take control of there we go. Perfect. The name of my talk today, one second. We're gonna run through Amanda's presentation quickly. Perfect. So the name of my talk today is Other Hereditary Breast and Ovarian Cancer Genes and Their Implications. So I may be using HBOC throughout the talk. So it does stand for hereditary breast and ovarian cancer. So as previously reviewed by Amanda, the majority of cancers are sporadic and only 10% of cancers are hereditary. And advances in the field of genetics has led to the discovery of the BRCA1, BRCA2 genes, but also several other genes that increase the risk for hereditary breast, ovarian, and related cancers. So Amanda already covered the BRCA1, BRCA2 genes, and I will cover most of the other genes during my talk. I just wanted to discuss a different risk level associated with different genes. And we have three categories, the high risk, moderate risk, and unknown risk. And high risk genes are considered if the lifetime risk of developing cancer is more than 40%, versus moderate risk genes would be the lifetime risk of cancer is between 20 to 40%. And then for the unknown risk, there are genes that have been discovered more recently, and the data that is available for these genes might be limited. So we can find general recommendations for each category. If we think of the high-risk genes, the medical management may include starting cancer screening at an earlier age, increase the screening frequency. We may recommend or consider surgical intervention, and as Amanda mentioned earlier, chemo prevention or medication to try to prevent cancer as much as possible. For the moderate risk gene, those recommendations may still apply, but it's more of a gene-to-gene basis, and we may want to consider the family history for the specific medical management for those moderate risk genes, and we will talk more about it throughout the talk. For the newly discovered gene, we try to base medical management on the family history until more data becomes available for the newly discovered gene. And okay, so as we can see, there are many genes associated with hereditary breast cancer, and I'm mostly going to focus on PALB2, CHEK2, and ATM for today. And if we start with the PALB2 gene, women with a PALB2 mutation have an increased lifetime risk of developing breast cancer, and this risk is estimated between 30 to 58%. And some data suggest that there could be a possible increased risk for a second primary breast cancer and possibly male breast cancer also. But more research is needed to describe to clarify those specific risks. There is also an associated increased risk for pancreatic cancer for the PALB2 genes. And there are some data that suggest additional risk for other cancers, including the ovarian cancer and the prostate cancer, but we're missing a lot of data before we can say whether there is an increased risk for these cancers and actually change the management for these cancers. So as of right now, it's more it is a possibility, but we wouldn't change any management for these ovarian and prostate cancers. So the focus for the management for the breast cancer, women with a PALB2 mutation are recommended to have an annual breast MRI and mammogram starting at the age of 30. And more recently, they also added the recommendation or the consideration of a bilateral mastectomy, which before it was there was not enough data to to consider the bilateral mastectomy for PALB2 mutation. There is also the possibility to consider pancreatic cancer screening, but we will talk more about the pancreatic cancer and why the family history does play a role in determining whether someone may want to consider pancreatic cancer screening. For the ATM gene, the ATM is considered a moderate risk gene because the lifetime risk for breast cancer is estimated between 25 to 30%, and there is a specific mutation that is known to have a higher risk for breast cancer. With the ATM gene, just like the PALB2 gene, there is also a known increased risk for pancreatic cancer. Again, especially if there is a family history of pancreatic cancer. Same as the PALB2 gene, there may be other cancers associated with a mutation in the ATM gene. Again, ovarian and prostate cancer. Again, we need more research to actually determine whether there is an increased risk for these cancers. So very similar to the management women who have a mutation in the PALB2 gene. For the ATM, the difference is the age at which we recommend to start the annual breast MRI and the mammogram, so at the age of 40 instead of 30. As we can see, there is currently insufficient evidence to support a preventative bilateral mastectomy for individuals with ATM mutation. Again, because of the increased risk for pancreatic cancer, depending on the family history, some patient may want to consider pancreatic cancer screening. So for pancreatic cancer screening, the recommendations are not as well established as other cancers, if we think of breast cancer screening or colon cancer screening. But what we know so far is that early diagnosis is still the most important way to improve overall survival by detecting pancreatic cancer at an earlier and treatable stage. Current research focuses on individuals at increased risk based on the family history of pancreatic cancer, based on a mutation, maybe both of them, depending on which gene the mutation is found in, and I will give some examples. And the surveillance for these individuals is recommended to start not before the age of 50 or 10 years before the youngest relative with pancreatic cancer. We briefly discussed the CAPS-5 study that is available at Yale with Dr. Farrell in our pancreatic cancer clinic. But really, surveillance is recommended for selected individuals who are at high risk and who may benefit from early detection of pancreatic cancer. So because it's still at the clinical research level, the benefits, the risk, and the cost of surveillance of pancreatic cancer definitely need more additional evaluation. The cancer of the pancreas screening, or CAPS-5, this study, they have very specific criteria. And when I know with our patients, when someone has a mutation in one of the genes listed here, we may briefly mention the option of pancreatic cancer screening, but I want to point out at the specific criteria to actually be eligible for the CAPS-5. So the only genes listed here that there is a recommendation of starting the screening regardless of family history is the STK11 mutation associated with Peteger syndrome, which we haven't covered yet. But all the other genes, BRCA2, BRCA1, PALB2, ATM that we've talked about, and some of the Lynch syndrome genes that we will talk about, having a mutation may not be enough to be eligible for CAPS-5. And it's always good to meet with someone to discuss the benefits and the limitation of the pancreatic cancer screening, but to actually participate in CAPS-5 more, it's not everyone who may be eligible. So sometimes even if there is no mutation that has been identified in the family, but there is a strong family history of pancreatic cancer and multiple relatives, individuals may also be eligible. Or if there is hereditary pancreatitis or chronic pancreatitis, those are also criteria. For the, moving on to the CHEK2 gene, just like the ATM gene, CHEK2 is considered a moderate risk gene with a lifetime risk for breast cancer estimated between 20 to 44%. And there is, most of the studies so far has been done with the specific 1100 del C mutation. And so all the data, most of the data that we have is really based on this common mutation in the CHEK2 gene, but there are other common mutations in the CHEK2 genes, including the I157T and the S428F, that are thought to only cause a slightly higher risk for breast cancer compared to the general population. And so with someone who has a mutation in the CHEK2 gene, again, there may be an increased risk for other cancers than breast cancer, including colon cancer, melanoma, prostate cancer, and male breast cancer, but more research is needed. The management, as you can see, is very similar to the other moderate risk gene, ATM. It includes starting a breast MRI and mammogram at the age of 40. And again, there is insufficient evidence to support preventative bilateral mastectomy. Because of that slightly increased risk for colon cancer, it is recommended to start at an earlier age for the colonoscopy, so at the age of 40 versus 50 in the general population, or around the age of 50, and not to exceed 5 years between each colonoscopy. I do want to talk about those moderate risk genes for ATM, CHEK2, and many other moderate or unknown risk genes. They, breast cancers and families who have a mutation in a moderate risk gene may be influenced by the number of family members with breast cancers, and it may, the risk of breast cancer may be higher in families that there is a strong family history of breast cancer. So it may be due to other modifier genes or shared environmental risk factors, but we need additional studies to fully understand how some families with an ATM or CHEK2 mutation have a very strong history, a very strong family history of breast cancers, and other families where we don't see any breast cancers. So when we meet with patients who are tested for the familial mutation, one of these genes, and their results are negative, or they are true negative for the familial mutation, we like to still screen them based on the family history, because that mutation may not explain the full history of the breast cancers in the family. So if there is a strong family history, even if someone tests negative for an ATM or CHEK2 mutation, we may still want to screen them more closely, because their breast cancer risk may still be significantly higher than the general population. Here's a list of other breast cancer genes that I'm not going to talk in great detail. I listed some of the cancer risks associated with these genes. There are newer genes newly discovered at the bottom here of the slide. And if you need any additional information for any of these genes, please feel free to contact our clinic, and we will be happy to review more information with you. But given the time limit for this presentation, I just wanted to pick one of the more common mutations. For the hereditary ovarian cancers, again, there are many genes that can, if there is a mutation in one of these genes, it can greatly increase the risk for ovarian cancer. BRCA1, BRCA2, reviewed by Amanda, explained a big part of those hereditary ovarian cancer. But I wanted to slightly discuss these newer genes or other genes part of a different hereditary cancer syndrome. If we think of the GRIP1, the RAD51C, and the RAD51G genes, they've only been clinically available pretty recently, so we need, again, I feel like it's a recurrent theme, we need more research, more data to better understand the risk for these genes and ultimately adjust the management based on this available data. But GRIP1 and RAD51C, the risk of ovarian cancer is close to up to 9%, and then RAD51G up to about 12%. And this is compared to the general population risk for ovarian cancer of about 1 to 2%. So increased, maybe not as high as the BRCA1 and BRCA2, but still a significant increase. There are some data that suggest an increased risk for breast cancer, especially triple negative breast cancer, when there is a mutation in these genes, but we don't have enough data to actually change the management recommendation for breast cancer screening for these three ovarian cancer genes. And based on the data that we have right now, it doesn't seem like there is an increased risk for men. But for the management, it is recommended to have a bilateral salpingo-oophorectomy, or BSO, between the age of 45 to 50. Of course, all these ages are dependent on the family history. It could be at an earlier age if the youngest relative with ovarian cancer had cancer before this age. So it is recommended to have the BSO around 45 to 50. And some individuals may want to do screening for the ovarian cancer, and this is with a transvaginal ultrasound, CA-125 blood marker, and a physical exam every year. Although the effectiveness of these screening strategies and early detection is limited. And as Amanda discussed earlier, some individuals may want to consider the use of oral contraceptives to decrease the risk for ovarian cancer over time. For Lynch syndrome, some individuals may associate Lynch syndrome with an increased risk for colon and uterine cancer mostly, but there is also an increased risk for ovarian cancer between 4 to 20%, depending on which gene the mutation is found in, and the list of genes associated with Lynch syndrome is listed here. But there are also an increased risk for other cancers listed here for Lynch syndrome. I want to focus on the ovarian cancer management, which is the same as the genes that we just talked about, the BRCA1 and BRCA2. The management would be very similar, except that we may also, if we remove the ovaries and the fallopian tube, we may also want to remove the uterus, given the high uterine cancer risk. But in addition to this recommendation, there are many other screening for the colon cancers, with very frequent colonoscopies and upper endoscopies for the upper GI cancer risk, and just an annual physical exam and dermatology exam, given other cancer risks. So in conclusions, some of these genes have been studied for much longer than others, and as we gather more data, the cancer risk we may get a better understanding on the cancer risk, and we may be able to change the recommendation for, the recommendation may change over time. And for this reason, it's really important to stay in touch with our program in the future to ensure that your personal cancer screening plan is best for you. Thank you. And I will present Elizabeth Del Buono, one of the genetic counselors in the Smilow Cancer Genetics and Prevention Program, who will be talking about the next presentation. There we go.
Okay, so hi everyone, my name is Liz for short, Elizabeth for long. I'm going to be talking about approaching the conversation or just different strategies for sharing your positive genetic test results if you did test positive for a mutation with your family members. So give me a second here. Okay, so why is it important in the first place to share genetic test results with relatives? Well, we know in most cases that parents, brothers, sisters, and children of the person who is found to have the mutation have a 50% or a half chance to have the same mutation. And we also know that other family members on both sides of the family are at risk to have that mutation. And of course, that's true unless we've already identified where the mutation has come from in the family. So if we already knew that it came from the maternal side of the family, of course, we don't think of the paternal side of the family as at risk. Another thing to keep in mind is that it's important to have the conversation with relatives about positive genetic test results, even if other family members have known about the mutation in the family for a while. And it's really important also to assume that relatives do not want to know. Remember that you're never actually forcing a relative to do anything by sharing your results with them. It's really just something that empowers them to make their own decisions. And ultimately, the decision to actually move forward with genetic counseling and testing for the mutation is up to that relative. So who is responsible for sharing the results with relatives? This question comes up very frequently. And it's generally accepted that the person who's being tested has a responsibility to share those results with other family members. The healthcare provider who's receiving the test results, like the genetic counselor or the physician, is not going to be the one to reach out to family members, but they might play a key role in helping to facilitate that results disclosure. For example, so some clinics like ours have consent forms that patients can fill out, and that will allow family members to receive genetic test results if they reach out to the clinic. So for example, if the patient actually wrote down those family members on that consent form, giving them that opportunity to reach out to the clinic. Genetic counselors in particular can help patients come up with strategies for sharing genetic test results with family members, you know, just like we're talking about now, but for their specific situation as well, especially if they're finding this really to be a more difficult task. Another thing that genetic counselors can help to do that we do quite often, I think, is help to create a family letter. So that would explain the mutation that was found in the family, how family members can access genetic services in order to see if they also carry that mutation, and just have some more general information that, you know, having it all written down for family members and creating that family letter can be really helpful. And in general, genetic counselors can be helpful in many different ways to patients who are struggling in this area or looking for strategies for their specific situation. So how will my family members feel about my test results? Another really common question. It's normal for family members to display a range of very challenging reactions when they're confronted with the news of a positive genetic test result in the family. So it's important just to understand that negative reactions are really common. So negative reactions like anger, frustration, sadness, even disinterest are also typically not directed at you personally. That's another really important thing to understand, is that this is something that the person is probably just thinking about this all at once. And even though these negative feelings might come out to you, it's not usually directed at you. So for example, someone might feel angered by just the disruptiveness that this information can have on their life and on their thoughts, and maybe what they had planned for that week and how, they're going to be thinking about this now. Others might feel anxious or alarmed by just knowing about the cancer risks that are associated with the mutation and thinking about how their medical care could change if the mutation were identified. Some people might just be worried about the risk to their children. Some family members might just be overwhelmed by the information or just kind of confused about these different topics related to genetics, inheritance. Some of these things people really have not thought about until they've, been kind of forced to think about it when they hear this news from a family member. A patient might feel guilty, for example, if they're a parent and they might know that they could have passed on a mutation to their son or daughter. And so maybe sharing that information with a family member can make them think about that. For example, a sibling could feel guilty if they test negative for the mutation. That's a different type of thing. But a sibling could feel guilty if they test negative. That's something that we call survivor guilt in genetics. On the other hand, some relatives might even use this information more positively and might display some positive types of responses or feelings. So some might feel empowered to use this information to address their cancer risk. Some might feel thankful for having learned this information and hopeful that they may be able to do something about the cancer risk. And still, some relatives might be dismissive of the information, or they might not seem to care at first, or just might not show any emotion at all, which can be frustrating for you as the person who's told this information to them. They could be passive, they can be indifferent. It's also important to know that family members' reactions to this information are really likely to change over time too. So someone who had a very negative reaction at first, maybe they were very overwhelmed and angry, they might sit with that information and end up feeling grateful for learning this information or encouraged to use this information and take charge of their healthcare. And I think that's a lot of times a really common response or change of feelings during this whole thing. Other family members may be indifferent in the beginning or say they don't want to talk about it, but they might eventually come around to you with questions and feel more open to that conversation. And overall, it's just important to be aware that these reactions are normal and expected really of anybody that you're going to be sharing these results with in your family. So when you're preparing to discuss these results, it's important to realize that you being fearful or anxious about having this conversation is completely normal as well. So just like we're talking about on the previous slide, it's important to prepare for the possible negative reactions from the relative that you're going to be speaking with. It's important to be aware that, okay, I'm feeling nervous right now about talking to this relative, and that's also a very normal thing. It's also important just to be aware of where those negative feelings that relatives have, or those responses that they might have that are sort of challenging. It's important to be aware of where those things come from, just like the examples that we talked about on the last slide. And it can be helpful to try to imagine how you might feel if you were confronted with this type of information. So if you were that receiving family member learning about the mutation in the family, what do you think your response would be as a member of the family? And more importantly, what would you want from your relative in that situation? So doing some of the things that you would want your relative to do to support you in that situation will likely be helpful for you to try and to do sort of in the same way for your relative. So maybe you're someone, for example, that really feels like they need to take some time and sit and think and read through something before having a conversation about it. Maybe giving your relative some space, allowing them to take some time to do that before talking with them more about it could be helpful after you initially give them that information. And keep in mind that what family members decide to do with this information is their choice. So as we said previously, the decision to share the information with them, ultimately, no matter how they feel about it, what you're doing is empowering them to make their own choice. So sharing results with estranged or distant relatives. So if you're estranged from any of your relatives, or if you feel like any of your relationships with some family members are awkward or just not as close as you really would have liked them to be, to have a conversation like this with them, there are many things that you can do to make sure that they have the information. So first, you might consider enlisting the help of what we call a linking or a connector family member. So basically, someone that you feel closer to than that family member that you want to talk to, who may also be closer to that relative. So this could be a linking family member more literally in your actual family structure. So maybe you have no idea how you would go about reaching out to aunts, uncles, cousins, first cousins once removed, second cousins, basically more distant relatives that you're just kind of overwhelmed by trying to reach out to them. You know that they're at risk, but there's just too many to try to reach out to them. So you might consider reaching out to your aunts, uncles, and cousins that you feel closer to, who might be closer to those individuals or know them a little bit better than you do, to help them or to help you to try to talk to them and reach out to them. And that linking family member might also be a family member that's linking in terms of a relationship. So not necessarily the structure of your family, like it's someone that's distant because they're a far relative, but it could even be someone like your brother that you just don't know how to talk to. So maybe you're not close with your brother, or you haven't talked to him in many years, but you know that both of you are actually really close with a cousin. So maybe your cousin could help you relay that information to him. Another thing to consider, kind of going off of that, is that you might consider just using different types of communication and what you would feel most comfortable with. So a family letter, like we talked about previously, is something that involves less contact. You can even make it anonymous. You can explain that someone in the family has been identified to carry a mutation, and this is what it means for the cancer risks in the family, and this is how you can go about seeking genetic counseling and genetic testing for that mutation. An email might also be more comfortable for some people. And if you would feel more comfortable having more contact, so maybe that's not something that you would feel comfortable with, just kind of having less contact, maybe you would like to have more contact, you could consider a phone call, or you could consider planning to meet face-to-face. Another really important thing to keep in mind is that depending on your family dynamics, it can be wise to avoid holiday celebrations and family reunions if at all possible. So some people will say, oh, it's perfect timing. I have this family holiday coming up. And that's not actually the best time a lot of times to share this information. So remember, like we talked about, that negative reactions from family members should be expected. So you may not want to share this information with someone at an event like this, because it could really intensify any negative reactions that they would have had. So for example, if you're at a family party, maybe people have been, having a lot of fun doing things like drinking or something. It might not be the best time to bring up this emotional topic. And instead of using this event as a time to talk about the results, it might actually be an appropriate time to let them know that you would like to call them or meet up some other time to talk about something important. So use it kind of as a stepping stone rather than as, the chance to talk about that with them. And lastly, if you have family members who have intellectual or mental differences, don't try to go about this alone and sharing those results with them. It's really helpful to involve other family members or their care providers when you're planning how you're going to share that information with that relative. That can be really helpful. So sharing results with your children. So when thinking about sharing results with children, an important piece of advice for children of any age, even adults, is just to answer questions truthfully. Another important consideration is to think about the age of your child and how much you would really want to dive into genetics concepts. So for example, for a young child, maybe 5 years old, they're just starting to learn about their body. You might consider incorporating this information and explaining, our bodies are made up of cells that carry our genetic information. This determines what we look like, how we grow. And as your child gets older, you can talk more openly about the family history of cancer. It might be easier then, a later time to talk about this gene mutation that's in the family that increases the risk for cancer. And then thinking about an older child, like a tween or a teenager, it's always a good idea just not to underestimate what they might be learning about genes and cancer from the internet, school, friends, other family members that you might not be aware of that may have already mentioned something about this to them. And then being honest with them is important. You can reassure them by explaining what you're doing to keep yourself healthy. Maybe share your experience of going through genetic testing in a way that feels right for you and your child. And depending on your child's age and their questions, you can connect them with a genetic counselor that can always be extremely helpful. So a genetic counselor can assist with determining the timing of testing and can help to navigate feelings surrounding testing. And even if your son or daughter isn't of age, or even if they are, but they're not ready to actually go through genetic testing, a meeting with a genetic counselor can help mentally prepare them for this in the future. Another question we get quite a bit from women with gene mutations that cause hereditary breast and ovarian cancer is whether or not to share this with male relatives. So Amanda hit on this quite a bit already. And the answer to this is, of course, yes, absolutely. And many genes, you know, like we were just talking about, we kind of went through this already, but it's important to keep in mind that many genes that are associated with hereditary breast and ovarian cancer also cause increased risk for certain cancers in men, like male breast cancer, prostate cancer, pancreatic cancer, and others. And those results do often impact a man's healthcare management, which we kind of heard more about. So for example, prostate cancer screening becomes a lot more important for men who have a BRCA mutation. Another important thing to keep in mind is the relatives of that male relative, right? So if he has daughters, for example, those are female relatives as well that would be at risk. So in general, you know, sharing these results with all of your family members is helpful equally. So hopefully that helps to clarify why it's important to share those results equally in the family. So thank you all for attending this talk and for this event. I hope that this specific talk helped clarify some questions or concerns that you have had about sharing results with your relatives.
Okay, looks like it's the question and answer portion of our session tonight. Thank you everybody for those great talks. That was excellent, and I'm sure I'm speaking for more than myself when I say that the past hour and a half just flew by. So let me see if there are any questions that we can answer from our audience here. So someone had asked about what is involved in pancreatic cancer screening. And since I'm not a panelist tonight, I'll let you guys tackle the current status of pancreatic cancer screening. It's not as black and white as something as breast cancer, but would anyone like to address that further?
I can briefly address it, but I can't remember what is the date exactly for Dr. Farrell's talk on pancreatic cancer screening. Anyone has the schedule in front of them? He will definitely go in much more detail about it, but pancreatic cancer screening would be some type of imaging, and then most of the time it would be either just an MRI, it can be an endoscopy, and they may start looking for early pancreatic cancer markers also, but he will talk more about it. Is it October 6th? Is that right?
That's right,
Yeah.
Camille. September.
Okay, perfect. So I would definitely attend his talk, and he will go in much more detail about what the results are of the clinical trials so far, and what the recommendations are.
Okay, would someone be able to talk about the timeline and process for genetic counseling and testing? So from start to finish, what does that process look like? How long does it normally take, etc.?
All right, I can take this question for the group if that's okay. So typically once an appointment is made and we're visiting with the patient and collecting information about their personal and family history, typically we get results back from genetic testing. If we're doing a full panel of genes, that can take as much as 3 weeks, sometimes a little bit sooner. If we're looking for or testing just specifically for a known mutation within someone's family, those results are usually back on average in 1 to 2 weeks. So sort of from start to finish, we are talking less than a month to meet with a genetic counselor after the appointment's made, to coordinate the genetic testing, which we're able to do in person. We typically are collecting a blood sample. When we're doing our telehealth or virtual appointments, we're using saliva based testing to collect the sample for the test, which then gets mailed to the laboratory to do the test. So the remote testing right now is taking a little bit longer just because it takes time to get the test kit mailed to the patient, to collect the sample and mail it back to the laboratory. So on average, that can add another week possibly. But blood work we can do and coordinate at the time of the in-person visit. So that does help expedite things a little bit more.
Great.
Is that all? Did I
Great.
get everything?
I think so. Yeah, that covered it well. So I know insurance is a tricky subject, and someone had asked about what insurance should be set up before genetic testing besides life insurance. So would one of you be able to talk a little bit more about things to consider before doing genetic testing insurance-wise?
Sure, I can field that question. So the other types of insurance that we don't have protections against discrimination besides life insurance are disability insurance and then long-term and short-term care insurance. So those types of things, if you're interested in obtaining those types of policies, some people do decide that they would prefer to do that prior to having a genetic test. And we also have just more helpful information and links about discrimination and sort of insurance concerns and things like that on our website. If you go to the fact sheets section of our website, we have a fact sheet about insurance concerns. So maybe we can link the website somewhere in the comments, Alex, so that people can check that out.
Yeah, I'd be happy to facilitate that, because I think someone had also asked if this talk would be available on the website, and I know we're recording it, but someone fact check me. It should be available on our website as well as the insurance fact sheet. Okay, let's see. So a couple of questions. I have one. One second. This is a very specific question, and to the patient or participant who asked this, I would recommend maybe speaking with your genetic counselor about this in more detail, who would know the specifics of your current situation, including your personal and family history. Let's see. So variants of uncertain significance. Would someone be able to talk a little bit more about the process of, or how we handle those currently, and the process of updating patients on information, or what can patients do if they have a variant of uncertain significance?
I'm happy to address these questions. So just for background information for those of us who may not be as familiar with a variant of uncertain significance, it's basically when there is a genetic change, we just don't know if the change actually increases the risk for cancer, or if it's just a normal variation that makes us who we are. So because most variants of uncertain significance are reclassified as a normal variation in the future, we treat those results most of the time just as a negative result until further reclassification by the lab. So most labs, and this is very specific for each lab, most labs, they work really hard to reclassify all of these variants of uncertain significance. And when they gather more information, more data on the specific variants, they are able to reclassify it as a normal variation or a mutation. And when they do so, they let the ordering provider know about the reclassification, and ultimately it is our responsibility to reach out to the patient to let them know about the variant, the reclassification. So there's nothing to do on the patient's end. It's really the lab that's working hard, and then they communicate their, those reclassification with us, who ultimately communicate the reclassification with the patients. So I hope this answers the question for what to do with the variant of uncertain significance regarding the follow-ups. And for the second questions regarding the age at which your son could get tested, most mutations and most genes, we don't recommend to test before the age of 18. There are some exceptions to the rule if there are increased risks for children, for cancer risk in childhood. And so with the CHEK2 mutation, the recommendation would be at the age of 18 or more, but we even recommend to wait until there's an actual change in the management recommendations, and or if they want to find out before starting a family. So the age of 18 or even later, if there's not going to be any changes to the management for the children.
Thanks, Camille. So as genetic counselors, we all have some experience with some of the emotional impacts, and I think Lizzie brought up a really good range of possibilities of reactions to these positive test results. So someone had asked if there are any psychologists or therapists who are trained to help deal with emotional challenges that can come as a result of genetic testing or dealing with those impacts. Would any of you like to elaborate on that further?
Yep. So we do have therapists who we have worked with and referred patients to who are interested in meeting with someone who is knowledgeable, both about either, in some cases, people want someone who works with cancer patients or survivors, but also specialize in understanding the uniqueness of having a hereditary predisposition. So we do have therapists on staff that we can refer to, or find providers local in the area who can also be of service to patients or their relatives. So just give us a call. We're happy to help provide information to anybody who would find it helpful.
Thanks, Amanda. So I think that's the last bit of questions. If anyone does have remaining questions, I encourage you to speak now. My panelists, I don't know if you guys have any final words or parting words of wisdom. And you did great takeaway slides, but last chance to leave our participants and guests with some information from tonight's session.
No, I mostly just want to thank everyone for spending, your night with us here, and hopefully with the weeks coming ahead, we'll continue to expand the information about these genes, hereditary risk, medical management, and the various options that are available to people who are at increased risk for cancer. So we appreciate you tuning in, and hopefully we'll see you guys and maybe even more next week. All right.